At OnlineMedEd, we walk you through every topic in detail, so you're ready for the boards and the wards. Addiction 2 is going to be where a lot of your points for the test come from. We're going to start off with alcohol intoxication, alcohol withdrawal, and then opiates. We're going to spend a lot of time on those because those are very commonly tested. And we'll finish off this lesson with a chart you just got to remember. The questions you're going to get are, is this intoxication or withdrawal, and of what? So we're starting out with alcohol, because alcohol, other than caffeine and nicotine, the diseases we treat as substance abuse disorder, it is the most commonly abused substance. Alcohol abuse has a predilection for men, with a ratio of male to female of greater than 3:1. And certain races are at risk for developing substance abuse disorder to alcohol, and those are Native Americans, as well as Alaskan Natives. Alcohol abuse does tend to cluster in families, so there probably is a genetic component, being it's both regional and familial. I do want you to learn a couple of different presentations. The first is alcohol intoxication. And while you've probably had some of your classmates get too drunk after a shelf exam, what you're going to look for is not what you've seen, but what the board likes to test. So intoxication is going to present with an altered mental status, but it is a depressant that leads to disinhibition. You'll also see slurred speech and cerebellar dysfunction. As it gets worse, they're going to lead to nausea and vomiting and may progress to coma and death. And if the person gets drunk enough, they'll have amnesia of being intoxicated. Those are all normal findings. Alcohol intoxication is life-threatening. Chronic alcohol use has different impacts on different parts of the body: the brain, the liver, and the GI tract. In the brain, you can have Wernicke's encephalopathy, a reversible cerebral disease where you're going to have cerebellar dysfunction and altered mental status. You can treat that by replacing thiamine and giving folate. Korsakoff's is effectively dementia. It is an irreversible loss of brain volume secondary to chronic alcohol consumption, presenting with primarily confabulation. Chronic alcohol use in the liver can lead to cirrhosis, which is accelerated by hepatitis C or hepatitis B infections. And lastly, chronic alcohol use predisposes to GI bleeds and gastritis. And while it does increase the risk of peptic ulcer disease, it in of itself is not an independent risk factor. And one particularly unique presentation is that of the coma, the man who's found down. Found down means we don't know what the cause of the coma is. We need to try to reverse things. Chronic alcohol use interferes with thiamine consumption, which is required for glucose metabolism. So if you find a guy down, you give him the coma cocktail, which, as we see, will treat both chronic alcohol use as well as opiate overdose. Thiamine, D50, and naltrexone. The thiamine first, so the body can process the D50 if that's the issue, and naltrexone to reverse opiates. The diagnosis of acute alcohol intoxication can be screened using a breathalyzer. Now, a breathalyzer is not necessarily the first step, but it can be used in the field. The blood alcohol content, a venous draw, is definitive. And the legal limit in the United States is 0.08, the legal limit with which you can operate a motor vehicle. Higher than 0.08, you're considered intoxicated. Below that, not. 0.08 is about 2 to 3 alcoholic drinks. And alcohol is unique in the sense that it is a zero-order metabolism. No matter how good someone is at drinking, that is, whatever their dependence or tolerance may be, a person who tolerates a blood alcohol level greater than 0.3 is obviously a chronic habitual user, but that doesn't mean their liver processes it any faster. The liver can process only 0.03 per hour, which is important in litigation. Whatever the blood alcohol content is when you draw it, you can extrapolate to find out how drunk they were when whatever event happened. It's also important. Most people black out, get nauseous and vomit around 0.2. That's really bad intoxication. But someone who's a chronic habitual user may be tolerant of the level of alcohol and may be functional at higher than 0.3. To treat acute alcohol intoxication, it's just reassurance, intravenous fluid and time. And if you've had a hangover before, you'll know hopefully your friends will bring you some Gatorade and some ibuprofen. You need to replace your electrolytes and keep them stable and deal with the pain and the headache that follows. Don't get that drunk again. To treat the coma, we talked about giving thiamine first prior to D50. To treat chronic alcohol use, that is, substance abuse disorders secondary to alcohol, the preferred therapy is going to be Alcoholics Anonymous, group therapy. It helps them get clean and stay clean. Pharmacotherapy is present, things like antabuse, but generally these don't work. It's a medication that, when ingested with alcohol, causes a disulfiram reaction. What the addict learns is, just don't take the pill and I can drink. It's supposed to be, if I take the pill, I'm not able to drink. So using group therapy is way better in the setting of alcohol. And I separated alcohol withdrawal because it's a completely different disorder. And it's also, benzodiazepine withdrawal is the same as alcohol withdrawal. The pathogenesis is this. Alcohol is a depressant. It stimulates GABA, and GABA is inhibitory to the activity of the brain. So what happens is that if you have chronic alcohol use, you're going to chronically stimulate an inhibitor. When that happens, the body wants to maintain homeostasis. So as you leave lots of alcohol around, in order to maintain the same level of activity, the body will downregulate the amount of GABA receptors there are. And then if you abruptly withdraw the alcohol and have decreased level of GABA, you have decreased inhibition, which leads to excess activity and excitation of the brain, leading ultimately to seizures. Now, the patient presentation is going to be variable, and we've developed the CIWA score, which is a subjective and objective measurement of how bad the patient's doing, and relies on things like nausea, vomiting, and headache. But what I want you to see is that there's an escalating level of neuronal activity. At the very beginning, what you'll see is diastolic hypertension and tachycardia. As there's more excitation, you actually start to see it in the muscles, and so you'll see tremor. Diaphoresis in these patients will be soaked, despite the absence of hyperpyrexia or even being warm in the room, are signs of early alcohol withdrawal. When the person starts bugging out, they get agitated, they feel their skin crawl, they gotta move, they feel restless, they feel anxious. That's the beginning of it getting worse because now it's in their brain. If they progress to confusion, that's delirium tremens, you need to intervene because what's right around the corner is a seizure. Alcohol and benzo withdrawal, potentially life-threatening. The diagnosis of withdrawal is going to be made clinically, no tests to get. And the treatment is going to be to leave enough stuff around to stimulate GABA so that they don't go into withdrawal. The way you do that is using long-acting benzodiazepines in a taper, chlordiazepine epoxide, diazepam. But you don't know if that's going to be enough, so at the same time, you also give them rapid-acting benzos, alprazolam, lorazepam, IV or PO. And so you keep them at a dose of long-acting benzo, giving them as needed rapid-acting until they don't need the rapid-acting anymore, step them down to the next level of dose of the long-acting, giving them rapid-acting as they need it, and eventually they taper off. This usually takes about 2 or 3 days. Benzo withdrawal is alcohol withdrawal. Both are treated with a benzo taper. Lastly, before we get to our table, is opiates. And opiates have gained a lot of attention in the media, which makes them great board fodder. The reason they have is because prescription pills is how people get started, and they end up doing heroin. Heroin can be snorted, but the big problem with heroin is intravenous drug use. Intravenous drug use leads to HIV, Hep C, and infective endocarditis. Sharing needles, reusing needles. You have to know about two states, the intoxication and withdrawal. The reason why people do opiates is for the euphoria. They're going to feel good and not feel any pain. The problem is that they might come in a coma. And what you can use as a clinician to suggest that this person has opiates on board is going to be a decreased respiratory rate and constricted pupils. While a patient may develop tolerance, needing more opiates to get the same euphoria, they do not develop tolerance to pupillary constriction. And a long-term side effect will be constipation. Withdrawal from opiates is non-life-threatening, but it hurts like a mother. If euphoria is the predominant symptom of intoxication, pain is going to be the predominant symptom of withdrawal. They also have nausea, vomiting, and maybe diarrhea. They'll have crampy abdominal pain, and because being in pain constantly sucks, they're going to be very irritable and emotionally labile. The diagnosis of intoxication can be made clinically or with a urinary tox, knowing that the U-tox turns positive almost instantly upon administration of IV opiates. So if a U-tox is positive in the ER and they were transported by EMS and EMS gave them something for pain, the urine's positive for that reason. You can do a blood test, but very rarely do you need to. Instead, what you can do is a naltrexone challenge. That is, part of the coma cocktail is naltrexone, because if someone comes in a coma, you just got to get it reversed. Thiamine D50, that doesn't work. Naltrexone wakes them up. The problem is, if you give a lot of naltrexone all at once, you interrupt the receptors all at once, you throw them into fluid withdrawal. So if you're mean, what you can do is give them a lot, have them puke all over the place, and then be in extreme pain. What you should do is give enough to restore the respiratory rate, make sure they can be not cyanotic on their own, and stimulate them to a RAS of +1. Just have them be awake without being in full withdrawal, unless you want to teach them a lesson, which isn't very kind. The treatment for acute intoxication is naltrexone. Again, give them enough to reverse the respiratory depression, unless you're mean, in which case you wake them up and make them puke all over the place. Chronic treatment, that is substance abuse disorder secondary to opiates, does work when you use Narcotics Anonymous, NA. But here, medical therapy actually works. Pharmacology is used in opiates. That is medical-assisted therapy with either methadone or Suboxone in tightly regulated and monitored settings can stimulate the receptors that cause the cravings and the withdrawal without getting the high. The idea is you stave off the reasons why someone might use physically, but you don't let them get the high that they want, which does reduce the use of heroin and prescription medications, as well as reducing the amount of unintentional side effects and deaths. We started this lesson, so I'm going to pause here before I move to the table to point out that alcohol intoxication, as well as chronic use, is a major topic. Alcohol withdrawal is life-threatening, benzo taper. As you see the escalation, try to intervene sooner so they never get to agitation or confusion. And opiates have picked up the pace. Naltrexone, as a diagnostic and therapeutic tool, and medical-assisted therapy does work. We're going to round out this lesson with just a table, and you're going to be challenged, which drug is it, withdrawal or intoxication? This chart is also available in your notes and represents the first half of the drugs we're going to cover. Alcohol we talked in great detail, but to review, acute intoxication is going to look like slurred speech, ataxic gait, impaired judgment and disinhibition, and patients are often tended to black out, that is, forget some of the night. Withdrawal symptoms are going to be hypertension, tachycardia, and it's going to progress on through delirium to seizures. The way you prevent those seizures from happening is a benzodiazepine taper. Of course, you're going to refer these patients to Alcoholics Anonymous and attempt antabuse. Antabuse generally doesn't work. Benzodiazepines are very similar to alcohol, except that they cause delirium in the elderly, and they are likely to cause respiratory depression and coma. Respiratory depression and coma don't usually happen because benzodiazepines are very safe. So you need a large dose of benzodiazepines or a combination with another depressant like alcohol in order to cause those problems. The way they are abused is actually as an amnesic. You see, benzodiazepines are the date rape drugs, where added to a girl's drink, she will then be disinhibited and not remember. Withdrawal symptoms are exactly the same for alcohol as for benzodiazepines, and so benzodiazepine withdrawal requires a benzodiazepine taper. If you have an overdose of benzodiazepines, you can use flumazenil. Flumazenil, however, does lower the seizure threshold and needs to be used with caution. Unless you are certain there is a benzodiazepine overdose, do not use flumazenil. Opiates, in their acute intoxication, can cause euphoria, but an overdose will look like pupil constriction, respiratory depression, and you may see track marks. Definitely looking between a user's toes to see if they're using the veins in between their toes, which they can hide. So no track marks will be found on their arms, but they might be found either on the penis or in the space between the toes. An acute intoxication, that is, an overdose, can be treated with naloxone. Naloxone, unlike flumazenil, completely reverses the opiate effects and has no side effect. Naloxone can be used freely. The only problem is if you use it in the hospital, that is, you are giving someone opiates and you think you gave them too much, giving them naloxone will prevent the effect of any opiate for about 12 hours. So if you're controlling pain, be careful how much you give. And if you give it too fast, you can induce significant nausea and vomiting. Withdrawal symptoms of opiates are yawning, lacrimation, sweating, itching, and all over body pain. You can treat the symptoms of withdrawal with methadone. Methadone takes the edge off. That is, it kills the cravings without getting the patient high. Cocaine is an upper. It's going to cause psychomotor agitation. They're going to be all active. Hypertension, tachycardia, they can even have violent psychosis. Their pupils will be dilated, and a side effect of cocaine intoxication is angina and hypertensive crisis. This is a vasoconstrictor which produces the hypertension and can also lead to the hypertensive crisis and angina. As they come off cocaine, they're going to go through a depression. So they were all active and up, and now they're going to crash hard. Some patients may even complain of cocaine bugs, that is, little sensation of bugs crawling on their skin. Acute intoxication or overdose requires alpha blockade before beta blockade. This is theoretical, but since they're causing massive vasoconstriction, if you give beta blockade first, you'll have unopposed alpha-1 activity, and your hypertension will get worse. Finally, in this section is amphetamines. Amphetamines, like NMDA, cause dilated pupils and euphoric psychosis. However, acute intoxication may also produce overheating. They're going to get really hot, increase their heart rate. And because they have lost the sense of water balance, they may constantly drink water, leading to water intoxication. As you come off amphetamines, you're going to crash, just like with cocaine, go into a deep depression. Essentially, the only thing you need to do for people intoxicated or withdrawing from amphetamines is supportive care. Moving on to the next half, we're going to start with PCP. Intoxication with PCP can cause aggressive psychosis, and these guys are really angry, really strong, and barely feel anything. These are the guys who can be tased and not be dropped. These are the guys who can stand up while they're handcuffed to a hospital bed. They have impossible strength. The way you're going to get the answer right on the test is they're going to mention vertical and horizontal nystagmus. Actually, in withdrawal can also cause severe random violence, so you have to be very careful with people who have PCP on board. What you can do for them is, one, give them Haldol to subdue them. You may need to use pharmacologic restraints in addition to physical restraints. And a sort of fun pharmacological point that might get you a point on your test is to acidify the urine in order to enhance excretion. LSD is rarely seen. It causes hallucinations, flashbacks, and enhanced senses. Withdrawal may also cause flashbacks, only requires supportive care. Marijuana, THC, the intoxicated state is going to show someone who's tired with slowed reflexes. They might have conjunctival injection that looks like conjunctivitis, and they may have the munchies. That is, they want to go eat. Too much of it, it's really hard to overdose on marijuana, but you can get symptoms of paranoia. There are no symptoms of withdrawal, and essentially you don't need to treat it, either intoxication nor withdrawal. If you do, it's simply supportive. Barbiturates, they have a very low safety margin. They cause respiratory depression and coma. They cause the same effect as benzodiazepines, they're just more dangerous, and that's because they redistribute into fat. And so this is more useful not for your drug users, but for actually anesthesiologists. If you give barbiturates, they're short-acting. So for short cases, they're great. But if, unfortunately, the case goes a little bit longer and you have to give an extra dose, it may take a long time for those to wear off. Barbiturates in general are low yield. And I've put in nicotine here at the bottom. I don't really consider it a drug, but it's in some of the tables you'll see in other review materials. Essentially, there's no intoxication from nicotine. You might get a little jittery. People use it as a stimulant, and if you watch Thank You for Smoking, there's a risk for ventricular tachycardia if you have an overdose. But in order to overdose, you need super high doses of nicotine. You have to try very hard. And if you try to stop using nicotine, that is smoking cigarettes, you're going to have some cravings. And so to get them over those cravings, you can use the nicotine patch, the nicotine gum, the medication Wellbutrin, or now the medication Chantix. This information is found in your notes, and I highly recommend you simply memorize this table close to your test date. There isn't a whole lot of useful information in here for practice because it is what you're going to see on the USMLE vignettes that point you to a diagnosis, not necessarily what you're going to see in real life.